Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. SGLT-2 inhibitors are considered some of the most beneficial drugs in modern diabetes care. They lower blood sugar, shield the heart, and protect the kidneys. But there's a biological tax for these benefits. They cause genital fungal infections, euglycemic diabetic ketoacidosis, and dehydration. These aren't random glitches. They are the predictable price of a single physiological shift. Under normal conditions, glucose is freely filtered at the glomerulus. Almost all of it is reabsorbed back into the bloodstream through the SGLT-2 transporter in the proximal convoluted tubule. SGLT-2 inhibitors flip the switch. They block that transporter. Instead of reclaiming glucose, the kidney excretes it through urine. Allowing glucose to remain in the tubular lumen sets off a chain reaction. The most common adverse effect is genital yeast infection, medically termed genital mycotic infection. SGLT-2 inhibitors do not suppress immunity. What they do is alter the local ecology by providing a continuous nutrient source for local microorganisms. By increasing urinary glucose excretion, SGLT-2 inhibitors create a glucose-rich environment in the genitourinary tract. Yeast, especially Candida species, thrives in warm, moist, sugar-rich environments. You are not catching an infection. You're fertilizing one. When the microenvironment shifts in favor of fungal growth, overgrowth becomes more likely. Clinically, this presents as vulvovaginal candidiasis in women, or balanitis in men. Now we move to the more subtle and more dangerous adverse effect: euglycemic diabetic ketoacidosis, or DKA. Classic DKA is easily recognized by sky-high blood sugar. But in SGLT-2-induced euglycemic diabetic ketoacidosis, blood glucose may often look normal or only mildly elevated, often below 250 mg per deciliter, even while the body's pH is crashing. So, what's happening? When SGLT-2 inhibitors lower blood glucose by promoting urinary excretion, circulating glucose levels fall. In response, pancreatic beta cells reduce insulin secretion. This is the green light for disaster. Insulin normally suppresses fat burning and ketogenesis. When insulin levels fall, that restraint weakens. At the same time, SGLT-2 inhibitors are associated with increased glucagon levels. This may be partly due to reduced insulin secretion, which normally suppresses glucagon, and possibly from direct effects on pancreatic alpha cells. The result is a higher glucagon to insulin ratio. And that ratio acts as a metabolic switch. Your body thinks it is starving. Adipose tissue releases free fatty acid into the blood. The liver converts them into ketones, acetoacetate and beta-hydroxybutyrate. The result is metabolic acidosis, a dangerous condition, as lowered blood pH impairs the heart, destabilizes electrolytes, strains respiration, and threatens survival. In classic DKA, insulin deficiency causes both severe hyperglycemia and ketone production. But with SGLT-2 inhibitors, glucose is continuously excreted in urine. So even though ketone production is occurring, blood glucose remains only modestly elevated. The acidosis is real, the normal sugar is a mask. And that is why euglycemic DKA can be missed. The final side effect is volume depletion. This is pure physics. Glucose is osmotically active. Think of it like a sponge. When it remains in the renal tubule, it creates an osmotic pull. Water follows solute. To put it simply, glucosuria pulls water into the urine. But there's more. The SGLT-2 transporter also co-transports sodium with glucose. Blocking it means you're leaving both in the urine. This double hit of sugar and salt strengthens the osmotic gradient, dragging massive amounts of water out of the body. We call this osmotic diuresis. Clinically, it looks like orthostatic hypotension, dizziness, and dehydration. The risk is amplified in the elderly, patients already taking diuretics and ACE inhibitors, or those who already have low effective circulating volume. Every one of the complications traces back to one pharmacologic action: the blockade of renal glucose reabsorption. That action causes glucose in the tract that feeds fungus, low insulin to high glucagon ratio that ignites the ketones, and osmotic pull that drains fluid from the body. Once you understand that, these side effects stop feeling like a list to memorize. They become predictable consequences. And that's the goal in pharmacology. Not memorization, but mechanistic understanding. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.